Hello everyone and welcome back to my channel. I hope you've had an amazing week. I'm Dr. Daniel Follows and this is GP Made Easy. Today we're going to be covering migraine as it's a common condition worldwide and there are many different treatment options, so hopefully you'll have a better understanding about it by the end of this video. But before we go ahead, don't forget to like, comment and subscribe so I know that you're enjoying this content. Anyway, let's get on with the video. So first of all, some background information. So it affects about 1 in 7 people globally, and it is found to be 3 times more common in women, and it most commonly affects people aged 25 to 55. And research has also shown that if you have a family history of migraines, unfortunately you're more likely to develop severer headaches and have it start at an earlier age. So, how is a migraine diagnosed? You have to have at least 5 attacks fulfilling the following criteria. The symptoms must last 4 to 72 hours. The headache must be characterised by at least 2 of the following criteria. So it is a unilateral headache, so it just occurs on one side, but in children it can occur on both sides. It has a pulsating nature, and the pain is moderate or severe intensity, or it is aggravated by activities of daily living such as walking, going upstairs, screen time, and the headache must be associated with some of the following symptoms such as nausea, with or without vomiting, photophobia, which is sensitivity to light, and or phonophobia, which is sensitivity to sound. And then finally, the headache must not be accounted for by another diagnosis. So when a migraine headache occurs, it tends to have phases. So the first phase is the prodrome phase, where there is abnormal neuronal activity, which tends to lead someone either becoming more irritable or fatigued or sleepy. They may get cravings, they may have nausea, or they may even have a decreased appetite. And this is when the photophobia or phonophobia can be prominent as well. The next phase is the aura phase, so only a third of patients will experience this, and it tends to occur about 15 to 30 minutes before the headache occurs. So 90% of patients tend to get visual aura, so they'll either develop scotomas or zigzags or lights or patterns in part or all of their vision, but some people may not experience this and instead they develop numbness or dizziness, or they might be paralysed, they may have speech difficulty or memory loss. And then the next phase is the headache phase, and this is caused by abnormality in the trigeminal-vascular system. So essentially the blood and nerve vessels to the side of the face. So essentially what happens is nerve impulses are fired off, which leads to the blood vessels to dilate in that area, which then leads to the headache. And then the final phase is the recovery phase, and this can last up to 2 days, and the patient may experience feeling unwell or poor concentration or just feeling tired. Now, as you can see to one side, I've put up the NICE criteria for what needs to be fulfilled for them to have what's called migraine with aura, as we discussed earlier. So have a read for yourself. So something to make you aware of is a condition called hemiplegic migraine. So this is where a patient gets a temporary unilateral paralysis, which is paralysis to one side of the body, and they may or may not have aura symptoms or a headache, and this can last up to 72 hours. Now with these patients, they need referral to be seen in the specialist clinic, and you also need to avoid triptans in these patients as they have an increased risk of stroke. So moving on to investigations. So migraine is mainly a clinical diagnosis, but some things that you would do as part of your full assessment would be to check their blood pressure to make sure they've not got high blood pressure as a cause. And you would also do a fundoscopy where you look at the back of their eye to the retina to see if there is a condition called papilledema. Now, if you're not trained or able to do this, then you can refer them to see an optician to have this done. So moving on to management. So first of all, we have lifestyle factors. So the migraine brain is very hypersensitive and doesn't like change. So you have to try and keep internal and external factors as level as possible. But I know for some things that can be quite tricky. So some things to consider is number one, keeping your glucose or sugar levels constant. So for example, not skipping meals, especially your breakfast. To keep well hydrated, so it's recommended to have 1.5 to 2 litres of water a day. Hormones play a part, so that's why in women they can have what's called a menstrual migraine, where they tend to get a migraine around their period, which we'll cover later on in the chapter. So if you wanted to manage this, maybe worth discussing with your GP if you may need to go on some hormonal contraception to keep those levels constant. High levels of stress have been shown to trigger migraines, so if you are having stress in your life, it might be worth having a review, see if any factors need changing. And sleep can play a big part as well, so it's advised to avoid sleep deprivation. So moving on to medical management, we have treatments that cover both the acute attacks when the headache comes on, and we also have preventative medicines to try and prevent the headaches coming on in the first place. So moving on to the acute attack medicines. So first line is simple pain relief such as paracetamol or ibuprofen or aspirin. So paracetamol is just the recommended dose on the packet. Ibuprofen is also the same, up to 400 milligrams, but in really bad episodes you can increase it up to 600 milligrams. And then for aspirin, it's recommended for high dose aspirin 900 milligrams when the headache comes on. The second line option, if they haven't worked, would be a triptan. You can either use it on its own or you can combine it with paracetamol or an anti-inflammatory. And if you're going to use an anti-inflammatory, the evidence has shown that the best combination is a triptan with naproxen. And if you think it's necessary, you can also add in an anti-sickness medication such as metoclopramide or prochlorperazine, even if there is no nausea and vomiting, because part of the theory is that where a migraine occurs in the head, also near the receptors that control your stomach, which causes the stomach to slow down, which can cause the things like nausea and vomiting, or even just decrease appetite with things not going through as clear. Just to make you aware, in under 16s, it's advised to avoid aspirin, as it can lead to a rare condition called Ray's syndrome, and the only type of triptans that are licensed in under 16s is nasal triptans. Also to make you aware that triptans are contraindicated in anyone who has got uncontrolled hypertension or if they have any cardiovascular disease. And if one triptan has failed, you can try a different triptan, and the triptan class has only failed if 3 different ones haven't worked. Other things to consider is caffeine, such as in cola or coffee, as this helps to push the gut along. It is also recommended not to use ergots or opioids, as these can cause rebound headaches. Moving on to preventative medications. So these are indicated if the patient's migraines are having a significant impact on their quality of life. So for example, if they are occurring at least once a week, or if the migraines are prolonged or severe. And for each preventative medication, you should at least trial them for 3 months before they're classed as failed. If you find one that the patient tolerates and has a good benefit, then you would continue it for at least 6 to 12 months and then review. And a preventative medicine is classed as successful if it at least decreases the frequency or intensity by at least 50%. So the commonest first lines we would recommend is either topiramate, propranolol or amitriptyline. In women, please be advised to check what their plans are for family in the future, as some of these medicines are dangerous to babies, so please take that into account. Candesartan is also another option to trial, and other options to consider are magnesium, riboflavin, coenzyme Q10, pizotecan, or even acupuncture. and if patients have tried at least 3 preventative medicines/techniques and they've had no benefit, then it advises to refer them to a headache clinic. Just a little warning as well, if someone comes to you and they've had a migraine for over 72 hours, then you need to send them directly to the emergency department. So moving on to menstrual migraine. So this is where a patient tends to get a migraine just before or after their period, and it's due to a drop in estrogen levels. For the headache, you can use the same acute treatments as we've mentioned earlier, or if it's debilitating or persistent, what you can try is giving them frovatriptan or zolmitriptan to take on the days that the migraine is expected, or to take from 2 days before their period is due to start until 3 days after their period has started. But just to make you aware, these are off-label indications. Also, another thing to be aware of, if any woman does have migraine with aura, then they need to stop their combined hormonal contraception, as both of these increase their risk of stroke or cardiovascular disease. Well, that's it for today's video. I hope you've enjoyed it and you've learned something new. Don't forget to like, comment and subscribe so I know that you're enjoying this content. And if you have any topics you'd like me to cover in future, then please comment in the comment section down below. I'm also on Instagram, so check me out on there. And if you'd also like to contact me, I also have an email address and it's just up here. Well, I hope you guys have an amazing week and I will see you in the next video.